Okie dokie. Right, we'll make a start. So good morning, everybody. My name's Tracy Smith. I'm Workforce Development Lead sitting within the ICB. I'm joined by my colleague Karen, who is from the Boost team, who will be chipping in. But also we've got Kay. Kay is going to help me and obviously facilitate some of this. I'm hoping that Martin's online.
Yes.
Can I see him? Yes. Oh, Martin's there. Great stuff. Thank you, Martin. That's great. So the purpose of today, we wanted to pull everybody together. As you know, as part of the Health and Growth Accelerator, we have a model that we would like to put in place as what the DWP Patient Advisory Service advisors are doing. And we want to upskill our workforce of those other people. So whether you're a work well coach, health and wellbeing coach, or other type of advisory role across the system, we want to make sure that everybody's got the right training, everybody is happy in what they're doing. And if we have got any gaps, we want to be able to identify those gaps and put some support in place for those people. So I hope that makes sense. At the end of the day, we're here to support you as the workforce out there. But we want to use the expertise that we've got out there in the system already, because we know actually a lot of you are already doing a great job at the minute anyway. So if I hand over to Kay, do you want to come in and give Martin a lovely introduction and a little bit about the DWP and the Patient Advisory Service? That'd be great.
Yeah. Hello, everybody. It's nice to see people join the call today. And we're going to be doing another one of these calls next month. We just haven't sorted out the dates yet, have we, Tracy? We need to align diaries. So this is just the first call of this collaboration approach that we've got between NHS trusts, local authorities in this case, and DWP, about us working together to support the people in our community, because this is what it's all about. So I've been working with the ICB for considerable length of time about understanding what's working well in the area and sharing the best practices. And one of those being our Patient Advisory Service, which we have had in, Martin will keep us right in a moment, he'll introduction, particularly in our Durham Tees Valley area for a considerable length of time, about 15 years, but that's now been expanded over into some other areas across other parts of the northeast, including Sunderland and Northumberland. This programme is evolved over that time. It is really, Martin has changed it and moulded it to really make it the service that it is today, to really help those individual patients. So this approach with the ICB and the Accelerator Fund, or Workwell as it's known in DWP, is about us working together. So where we got the Patient Advisory Service and then Workwell, widening this service out into more practices that we don't have the service in. So the idea being is that collectively between together we can support more GP practices and more people within the community. So it's lovely to see people on the call today, and I would like to introduce to you Martin, who is our very experienced. We've got multiple patient advisors, don't get me wrong, we've got lots of colleagues doing a brilliant job, but I think Martin lives, sleeps and breathes it and has done for a long period of time, and has really built the foundations of what it is known today. And it's the principles of the approach that Martin's had across the Durham Tees Valley area that the Accelerator Workwell program's been designed on. So Martin, I do know Martin's not being well at the moment, so I don't know whether Martin will be able to put his camera on or not, but Martin, don't feel free to put it on. Feel as though you have to put it on if you're still not very well. I'm just grateful that you're able to join today when you're not well. So are you there, Martin?
I am, but my internet.
Oh, I've lost your sound on you there, Martin.
No idea where we are.
Oh, yeah, you're there, are you?
Yep.
You're there. Oh, I can hear you now. Thank you.
Yeah. I don't want to put my camera on because the internet keeps cutting off here, so I don't want it to completely take us out. So right. I've just completely missed your introduction there, Kay, so sorry.
Oh, well, you didn't hear us praising you there, Martin, so there we go. It's being recorded, so you can look back at it later. So, thank you. Right, Martin, do you want to, sorry, what it is, Martin, you've missed that call there. I was just explaining that you're our most experienced patient advisor and within DWP. So would you be kind able to come along and explain a little bit about your role, how it's evolved, and what you see, what is the purpose of your role? So is how you work with the patients and within that GP practice structure, and just give a little bit of insight into your role, please, for colleagues on the call today. That'd be great.
Yeah, so originally I set up the Patient Advisory Service in Tees Valley in 2008. So the service has actually been running in Durham Tees Valley since 2008. What is our purpose of our role? It's basically to support the GPs, to support the patients more effectively. You have people going in there for fit notes that aren't necessarily going in for fit notes for a medical reason. It could be a situational reason. It could be a combination of health and situation, or it could just be a health problem. And a lot of people are basically stuck in a rut and not being able to deal with the situation that they're in, which is then affecting the health.
Or something? Oh, can somebody put that somebody put themselves on mute, please?
So why is this important? This is from job centre language. So from a job centre's point of view, if you've got somebody who's struggling at work and they actually don't access any support, they generally wouldn't contact the job centre till week 26 or week 28 of the claim, when they're actually either making a claim to some sort of universal credit or employment benefit, or the statutory sick pay has run out and they're not quite sure what the next step is. Now, the problem that you've got there is the further you get away from the initial problem, the more that you're dealing with the symptom of a situation, i.e. relationship breakdowns, financial problems. And by the time they get into the job centre, we're never actually dealing with what the original problem is. We're always dealing with a symptom of a situation. So by the time they actually get to us, we've lost an awful lot of those patients before they get to us, which is why by front loading the support, it actually allows us to deal with the patient effectively and actually deal with what the problem is. There was a study done by Laura Shemtob, who was the Imperial College Lead for Occupational Health, that said 1 in 5 people, when they reach 4 weeks of a fit note, never return to work. By the time that gets to week 28, that's up to 4 out of 5 people never return to work. So from a job centre point of view, we've lost 80% of that cohort before they actually get to us. So it's front loading that support so we can actually deal with the problems that the patients actually have within the work environment. The POS services has no restrictions on who we see. It's not time bound. We'll work with anybody from day one to, we've got people back to work that have been on benefit for over 30 years by giving them support. Why does the PAS service work? It's the environment. It's the fact that it's a voluntary service. We're giving the patients an environment that they're comfortable to talk in. They go to their doctor's surgeries to tell, which is very different sometimes how they feel about going into the job centre, which allows us to actually get the information we need to actually support that patient early and actually deal with the initial problem, allowing that then not to expand into something more serious. It's basically, we need to be integrated.
Oh, I've lost you there a second, Martin. Has anybody else lost Martin?
Yeah.
Oh, you're back there. Sorry, we missed out for a minute or two, Martin. Sorry, for a second.
Okay. It's really important that we integrate the service within the surgery. It needs to feel exactly the same as a GP to refer into work support as what it would do to refer into a blood test or a diabetes assessment, because the work and health things are completely bound. They are very, very linked, and it's one of those where the in the market, the quicker you can actually move that patient forward. It also allows the surgery to give an holistic approach to patient care, because you're not just dealing with the crisis point, i.e. the health problem. You're actually dealing with the underlying issues at work that are probably contributing to that one. So if somebody's had a dispute with the employer, they're going to present with work-related stress. They can be medicated, they can be counselled, but if they're going to go back to exactly the same situation, it's going to be reoccurrent to patient to be able to deal with the problems at work, whether that needs to ACAS, but it's actually getting to the root cause of what that patient, why that patient is actually coming in to get that fit note. Is it a situation?
We've lost you again, Martin. Sorry, the signal must be. Hello, are you there, Martin? Give it a second. Martin, are you there? Sorry, we've lost you. No, seems as though we've lost Martin at the moment. He's probably still talking, probably not realising.
Martin, if you can hear us, I wonder if it's worth doing the old classic, going out and coming back in again, see if you can get a better connection, because sometimes that works, doesn't it?
Yeah. Sometimes if he's in a GP practice, it's sometimes about depending on where the signal is.
Right.
Actually, likely is. Right, yes, we'll get that link to the publication. We'll just talk about things in the moment. So what Martin was really explaining about his role as a patient advisor, and this is the same principle of the work well coach, is to understand the person is a holistic approach. So yes, we are not medical professions and Martin's not medical professions. So in that first encounter, Martin wants to understand, what does that health condition that a person's reporting to the GP practice mean to the person is in? It's not about the label of the condition. It's about him. Oh, you're back. Are you back there, Martin?
I think so. Yeah,
oh, you're back.
See how long we last for.
Sorry, I was filling in some gap there for you, Martin.
Okay.
Are you there? No. Right, I'll carry on, and if he comes in. So I was just explaining it's about understand. So he uses that first appointment for to help understand and how does that health condition affect that person when it comes to work? So does it mean that they can't stand for long periods of time, can't sit for long periods of time? Is it an emotional aspect? Is in you can say there's conflict at work? Is there the environment that they're working in or they're struggling with? Does Martin need to maybe help the person to have the conversation with their employer, or does he need to support with that conversation itself? Or does the person need referring to, say, additional occupational health support, or referring to any other community support that's available? It's understanding not the health condition, it's understanding how that health condition affects the person's ability to work and what's stopping them from returning to work. Then working with them to set. Martin sets small steps and small goal steps. So the idea being is keeping that person moving forward at all points. So if he's setting them on a weekly basis, fortnightly basis, whatever it is for that person, each intervention is a goal set in place. So there's something set for them to work towards, ready for the next person. So keep that positive mindset going for to help move that person forward into work. So, Martin, are you back or are you still there?
Yeah, I'm flitting in and out, I think. Sorry.
You're flitting in and out.
I think I'm back there.
Yeah, I think you're back now.
Can
so
you
I'll
hear
let
me
you
now?
carry on, Martin, then. Fingers crossed. We're having teething issues today.
So what I'll do is I'll go through basically what our interview process looks like. I mean, we work on system 1, so there's no paperwork involved for the GP with our referrals at all. They literally just book the appointment straight into our sessions. And obviously we can pick up any referral notes via what the GP's put on the notes for us to have a look at there as well. The initial interview from our point of view is all about consent, so they know who we are, what they are, what our role is, what we're there to do, that we will feed back to the GP and give you GP updates on progression. The initial interview is the only interview where we basically let the patient talk about health. We make it clear at the end of that appointment we're not there to support them with a health condition. We're there to help them with the situational stuff, take into account the barriers that the health actually gives them. So we can look at amended duties, we can liaise with occupational health teams, we can liaise with employers to build a back to work plan for that patient. And then we can pass that information on to the GP to start to use as a maybe fit for work note. So changing that sick note in effect into an actual maybe fit for work note. We do an awful lot of work around goal setting within the patient, within the surgery with the patient. So what's realistic to them? What do their capabilities allow them to do moving forward? And more importantly, allow them to sustain moving forward? Because what we don't want to do is put that patient back in a situation where they instantly crash and burn and end up coming bouncing back to the doctors again. We need to make sure that that transition back into work is right. We do give the patients a lot of homework. We do keep them busy. We do a lot of work around what's important to them. We give them a lot of reflective exercises to do, to go away and think about what they've done before within the role that they're doing, what sort of skills have they got that are transferable that we could potentially use to other roles. So I think looking back at the figures that we've got, about 40% of our people that come to us actually go back to work in different employment. An example of that is your labourer with an arthritic problem. We've got to start having that conversation, is how long they can sustain that role. The role that they're doing is probably damaging the condition. What transferable skills have they got to move into another role moving forward? Can we liaise with that employer to get them back on amended duty so they're doing a slightly less physical role to allow them to return to work? But we would continue working with that patient to help them find what the long-term sustainable solution is. Because if we find the long-term sustainable solution, they've got better management of their health, the health condition isn't deteriorated, they've got better wealth, and they're in a better position to move forward and take control of their own situation. Within the surgery, we will do anything from CV preparation, job search techniques, interview practice, identifying additional needs. So do they need different equipment? Do they need specialist chairs? Have they had risk assessments done by the employer? Is the bad back caused by the fact that they're sat in the wrong position? So do we need to get occupational health involved to have a look at that to make sure that the patient's accessing all the right support within the environment for themselves? So we can tap into support through the likes of access to work, job centre services. If people are having financial issues, we can work with Welfare Rights, Citizens Advice Bureau. To build on the goal setting techniques, we can use things like National Careers Service.
I think you've gone again. I think for our next call, we need to learn this is a lesson to have an environment where we can all access teams properly. Bless Martin, he's doing this in between his appointments that he has in the practice as well. Oh, you're back there, Martin, are you?
I'm back.
You're back, sorry. I'm seeing we're just having problems. Are you in the GP practice today as well? I am in
the GP practice today. That's why my Wi-Fi is rubbish. That's government web for you. So it's establishing everything that's positive for that patient to allow them to move forward in a direction that's going to give them the long-term solution. It could be the main issue that go and see the GP is a housing issue because they're stressed, they're anxious, they need time away from work to sort out what's going on. So there's an awful lot of information available in the Make Every Contact Count website. So if there's housing issues or which is via www.neccgateway.co.uk. There's an awful lot of information on there because the reality is in this role, there's something new every day. You will never know everything. There's always new problems and new situations come up. So it's accessing the tools to make it easy for you to move forward. I think the main thing to stress is this isn't about a health conversation with us. You've got your GPs, you've got your nurse practitioners, you've got your mental health practitioners and your social prescribers in the surgery, all are looking at it from a health point of view. We've got to look at it about what those barriers are and how we can overcome that barrier for that patient moving forward, which obviously has to take into account the health condition, but not in any great detail. It's how it affects them on a day-to-day basis. What's the benefits to the GPs? If we get the long-term sustainable solution, it's less appointments for the doctor. There's no need for that person then to transition into benefits. They're in the right role, which will allow them to manage the condition more effectively. It's support with that fit note and changing that fit note from a sick note to a maybe fit for work note and working with employees and occupational health teams to establish that route forward for that patient to return to work. But also it's using that window where you get them on amended duties to work with them to find what that long-term solution is moving forward, because it may be a very different career path to the one that they're already in. I'll give you an example of a time and a cost saving that we got for one of our GP surgeries. I had a lady referred to me who'd been on benefits for 6 years. In the year before she'd been referred into the PAS service, she'd had 116 appointments in the surgery, whether that be blood tests, GP appointments, mental health practitioner appointments. She hadn't worked for 6 years. She had no real direction. She was socially isolated. She only ever went out to go to the doctors. We did a lot of work around goal setting and what's realistic and latching into hobbies for her. We worked with her for 6 months, initially transitioned her into some voluntary work, which then ended up becoming paid work. 6 years later, she's working now for the same company. She's managing 3 premises. She's a published author. In the year following going back into work, she'd had 4 appointments in the surgery, and 3 of them were with me for in-work support. So she only had 1 medical appointment in that time. She'd come off 4 lots of medication. She decided she wasn't disabled anymore, so she'd voluntarily decided to come off a PIP benefit as well, which she could have kept on. But she decided she wasn't disabled now. She didn't need that benefit. And she's doing phenomenally well. I think the main benefit for patients, and I'm sorry I'm rushing this, I'm trying to do this before my internet goes off again, is we give them the environment they're comfortable in, where they want to talk, they want to tell us where the problems are, what the issue is. It's a voluntary service. They know they don't have to be there. We're giving that patient control over whether they come back to us. Now, we fail to attend rate of around about 2.5%, which for what we actually do is a ludicrous figure. We have to want that patient to want to come back in and access the support because they don't have to. By getting the right outcome, they can manage their health condition better. They'll have a better quality of life. They'll be able to sustain work. It will take a lot of the stresses away. It'll take a lot of the financial concerns away, and they'll actually be in the right place moving forward. We do offer in-work support as well. So once that person goes back into work, we will carry on with in-work support to transition them back in, just in case there's any issues in the first couple of months. So we might do a review after 3 weeks and then 6 weeks and then move it to maybe 2 months just to see everything's okay. Because I think generally if there's going to be a problem, it's going to be in the first couple of months that they actually do return to work. Our services currently in Durham Tees Valley, we're working at 74 sites actually have access to the service, but whether that's via face-to-face or telephony. We're actually face-to-face in 34 of those sites. Of the 20 PCNs the 27 PCNs in Durham Tees Valley, we've got a presence in 20 of them. There's over 300 GPs use the service. And we're really, really proud to have supported over 2,200 patients back into work and sustained work. And the fact that now we have patients that self-referring to us when they're having an issue at work rather than going to see the GP because they realise it's a situational problem, I think is a mark of how the patients see the service moving forward as well. I'm just going to open that up to questions before my internet dies again.
Thank you, Martin. Thank you. It's important. The idea being is there was Martin was just going to give colleagues on the call an idea of how his role fits in amongst it all and where you see that, because it's really important to understand that we're not health experts. We're not expected to be health experts. We're just there to navigate that person through the challenges they're facing. This is what the idea being is that the Work Well programme. So does anybody want to come along and ask any questions of Martin at this point? Any of our other PAS advisors, because we've got other PAS advisors on the call, and they can feel free if they want to come along and introduce themselves, if they want to put their hand up and introduce themselves and say which area they cover. I know we've got some on there. I'll start picking on you if you don't. Jason. Hiya, Jason.
I'm here as well. I can only really reiterate what Martin said there, that really what we do a lot is like we call it hand holding, and we try and support and encourage as best we can. Quite often we're dealing with people here who just haven't done anything for a number of years, and it's about those small baby steps. And if we can progress them that way, then we kind of think job done,
I think that's one difference is we've got to understand is our patient advisory service, you'll hear that is we do not have an eligibility criteria. So we offer that support to any patient who feels it may benefit them. With Work Well is a bit different. There is an eligibility criteria, and it's for those people who are either recently gone on the sick, so they've gone on the sick and they're in work. So if they're still in work, or have recently come out of work because of their health conditions. So it's a bit different to what we have as a patient advisory service, but the same principles apply regardless. It's that Martin said, that early intervention to get them back, help them retain and work. So what do we need to do to put in support to get them back into that job they've already got, or another job, or help them get back into the labour market as soon as possible? So
sorry, just another thing to add there as well, Kay, that obviously, and I should have said before, actually, you know, I cover the Northumberland area. There's me and a team of 3 of us, but we also talk a lot about that, I guess, the financial benefits of working. Now, financial benefits of people who are on benefits is a massive thing to discuss, because a lot of them will think naturally that they're worse off for moving back into work. And actually talking to them about what their entitlements are in terms of that side, I think is really, really important. Because I think once those guys get an idea that actually going into work financially is also a positive thing, and that they're not going to be worse off from what people have told them on the street, is a huge factor as well. There's no question about that. So we certainly spend quite a bit of time talking about those things as well.
Thank you. Fee?
Sorry, hi Kay.
Hello. Hi.
Thank you, Martin. And was it Jason that was just speaking?
Yes, it was. Yeah.
It's really interesting to hear more about your role, and it sounds like you're doing an amazing job. I just wondered, there's a couple of things. I wondered what you thought were your key challenges in your role, and also you obviously gave a lot of detail about supporting a patient. But I wondered if you did any work sort of on the front end. So I wondered if you did work around the disability confidence scheme and supporting employers to sign up to that scheme, and also like if you provided training and support for employers around reasonable adjustment, I don't know, that kind of thing, to make them a better employer as well.
I'll let colleagues answer the first question. The second question, we've got other colleagues that will support with the employers themselves regarding disability confident and regarding about people with disabilities. So we've got disability employment advisors, which we've got Michelle's put a hand on. So we've got other colleagues, and we've got employment advisors as a whole. So I'll let a couple of those colleagues come on, Faye, because as a DWP, we've got wider teams. Martin, Jason, do you want to answer Faye's first question at all about the challenges you have faced and about any of the employer activity that you do have?
Sorry, Martin, you go ahead.
I think challenge-wise, I think initially it was embedding the service. It was getting the referrals, certainly initially, because we went in was something that was brand new. I mean, we went in 2008. That was long before even social prescribers existed. So I think at that point we were actually also doing a social prescribing role as well within that. I think we've got the opposite problem now, certainly in Tees, where we could do with cloning because of the amount of referrals that were coming through and volume, because we're doing probably a minimum of 16 appointments a day in most surgeries, and most of our surgeries are still booking weeks in advance. So we've got the interest. It's acting on that interest. I think where the conversations with employers happen is more so when we liaison with the patient on what's realistic for that person to go back. So we could have 3-way conversations with the patient and the employer, or we could upskill that patient to have that conversation with the employer, because that's the way. I think a lot of our role is upskilling the patient to be able to deal with this situation if it comes up again. So we do pass a lot of the onus back to the patient by saying, this is what you should be doing, this is what you should be asking for. Yeah. These are the things that you're actually entitled to. Are you accessing occupational health support? Do you really need that reasonable adjustments doing in the location that you want to do there? And that's probably where we would deal with employers, because I say that there are other teams and other hands up there that could probably answer that question better.
Yeah, thank you.
Haley? Oh, sorry, Jason, did you want to come in there with something there? Sorry.
Yeah, I was going to say, really, in terms of problems or any perceptions, I can honestly say in Northumberland, I think we've been fantastically lucky. I mean, I think we kind of initially went in thinking we were going to have some issues, but actually things have just rolled on fantastically. I mean, we're now in approximately about 15 surgeries across Northumberland. I'm up in Amble today, and really things hit the ground running. We really, once we got through the initial kind of DBS checks and smart card problems, I mean, we were just inundated with referrals. I mean, we have one particular surgery in Ashington, for example, that we've had probably about 400 referrals over the last 18 months or so. It's been ridiculously, and it's gone on, going back to what Martin said there about the fit note process. In 2 or 3 surgeries that we go to now, we are actually, I guess, part of that fit note process. So quite often, a lot of GPs will say, we get fit note requests coming through to us to say we need one for the job centre. And we've put like a little bit of a triage process in place where if any fit note requests come through that mention we need this for the job centre or for universal credit purposes, they send those requests to us. That is for us to contact those guys and just to say to them, look, you've sent a request in, find out some more reasons why you need it, get some more context as to why you need it. And actually there's quite a lot of those requests that come through where people actually just don't need a fit note. So we can try and nip that in the bud pretty much straight away. We had a guy a few months ago. Yeah, we had a guy a few months ago that when I looked at his sort of claim, I was like, why on earth is this person requesting a fit note? And actually, when I spoke to the gentleman, he said, well, I just wanted it for my own records. And it was, well, you're just wasting people's time. Basically, you don't need it certainly from a benefit perspective. You just don't require that. So that kind of stopped that happening as well. So what we then do actually when we speak to those guys about the fit notes, if a fit note actually is appropriate certainly for the benefit side of things, we always then encourage those people to come and see us in the surgery, so then we can then try and explore what's going to happen next thereafter, and we can slowly but surely sort of start discussing that the longer term, the future basically, and what they would like to do down the line. So that's worked really well in about 2 or 3 surgeries that we go to.
Lovely. Thank you. I think the hardest part in the beginning is getting that buy-in, as Martin said, but I think Workwell is opening up some doors with some surgeries that didn't do that, and we just don't have the resource to expand this further. So this is going to give other practices. Martin's got a waiting list of practices that would love to be part of Patient Advisory Service. We're not be able to do that. So this collaborative approach is going to allow that support to be widened. Which is brilliant.
I think one thing I've noticed since my time, of doing this as well, is that, we have a lot of people on benefit who, I suppose, technically don't have to be seen to be doing anything because of their benefit entitlement and the way that's been set up. But it's amazing with some of those people who are on sort of long-term sick, if you like, who would like to do something. Now, it may not be 40 hours per week, working, because they might not be able to manage that. But actually, they're quite happy to discuss doing something for 5 hours a week or 10 hours a week or 15 hours a week. And we know those small baby steps that if we can get them involved in that type of stuff, it might then just snowball. You know, it's that longer term picture,
Brilliant. Hayley, you're waiting patiently there with your hand up.
Hello there. Hiya. I was just going to respond to you with regards to the disability confidence side. So within the previous Durham Tees Valley District, I was the disability confident lead, and that's moving across now to the Cumbria and Tees. So part of my role is contacting all of our employers that we have at level 1s, 2s and 3s, educating them on the disability confidence scheme, and helping them progress through the levels and seeing if there is any additional support and things that they need moving for that. It's also I contact employees who aren't signed up to the scheme as well to see if they would like to join, which then can run alongside, with regards to Martin, because I'm the patient advisory lead for the Cumbria and Tees as well. So alongside that, Martin may potentially have somebody who would benefit from some work experience to see if that's a kind of role that they would like to have. Due to the links that I've got with the employers, I can then contact them and maybe put them in touch in order to look to do some work experience to see if they would like to to be involved in that as well. We've also put conferences on previously where we've had a number of employers at level 1, 2 and 3 where we celebrate the level 3 leaders that they've achieved that status, but also we mix them with regards to on different tables, levels 1, 2 and 3, so they can liaise with each other and get hints and tips on how they can improve and move forward as well. So there is a lot of work that within our district that we do with regards to the disability confident.
Thank you.
Okay.
We'd like to say that we're looking, Tracy probably covered this anyway, so we're going to be looking at setting this call up. This is the first one, we'll do another call, but we're going to be looking at this collaboration, maybe it's on a monthly basis. So as WorkWell coaches come online and on board, they can ask these sort of questions, what you've just had fear other colleagues have got. We're looking at also setting up a SharePoint page if we potentially can. We're looking at the fundamentals of it, so a bit of a Q&A. So if a colleague is one of the WorkWell coaches is really stuck, they've got a patient, they really don't know what to do with that individual, they just want some advice, they can maybe put a question into the SharePoint page, and one of our experienced PAS advisors or another WorkWell coach can pop on and offer some advice and support. So we're looking at that coaching and support network available between everybody. Right, who we've got next, Tracy? Karen.
Thanks, Kay, and thanks, Martin and Jason, for sharing your story. I just think it's such a brilliant work, and it's I'm just starting to learn now about the WorkWell coaches and the differentiation and how it all fits together. And one of the things I was really struck by is that the timing thing around the more the weeks go on, the trickier it becomes. And so but I work as a mediator alongside my day job and have been involved. Same principles apply, really. The more passing of time when it comes to conflict or tricky situations, the harder it becomes to sort of reconcile. And I have worked with people off of work who are very clearly suffering from a physical and mentally because of some kind of workplace conflict. And I can just think of one story over the last few years where having worked with a member of staff and managed to get them together with their line manager for a sort of facilitated discussion within half an hour, some of the stuff that person had manifested around what they thought might happen disappeared, and they very quickly went back to work. So I would definitely advocate mediation as a way of in some circumstances supporting people back into work. I guess the question that I wanted to ask, and I think it's to you, Kay, is because I'm still learning and working with Tracy and Julie around this, and obviously I'm housed in the ICB, is our role in Boost is how do we support, how do we might be able to host the community of practice, for example, that you talked about there, which sounds absolutely brilliant, and that SharePoint piece, which sounds great as well. What else is there potentially from UK, from your end, around supporting the WorkWell coaches? Because obviously they're going to be housed and hosted by different organisations. I was just wondering what other services you provided or how else you could support.
We've got MEC, which was mentioned before. So what we've done is all of our colleagues over the last few weeks, because we were aware of this, and at the minute we've got internally in DWP, we've got our district provision tool. So all of our services and support systems that some of them Martin was rhyming off before, we've got them on our internal directory. Unfortunately, like outside organisations can't view that. So we've done a lot of work with Craig, and Craig's got his hand up about with WorkWell, and we've been getting a lot of our support partners that we would use built into the directory in WorkWell. I would encourage other colleagues on the call, so if you're an NHS trust or local authorities at the moment, have a little look at WorkWell, have a look at the support offers that you have. If it's not on there, get it built in now, potentially, making sure that directory is there so that we can all use that. So that is the support system. Myself and Tracy are looking at, Tracy's building up obviously a support package on the softer skills and the coaching and the mentoring and how you get that positive mindset coming, because that is very, very important. Otherwise you can get stuck on a rabbit hole if people just constantly talk about what they can't do rather than looking at what they can do. But then, as we did say that we would support and be coaches to WorkWell colleagues, however, very conscious that, like Sir Martin and Jason and other colleagues on the call today have got full diaries of 16 patients a day in some instances, so they can't be at on call all the time. So this is why we need to look at some online tools so they can put the question on at the end of the day or the beginning of the day. Colleagues can just pop on and offer some advice onto that. When we mentioned before about jobs fairs and employment opportunities, it maybe is worthwhile. I'll speak to other colleagues about sharing our local employer advisor contact details as well. So if we've got any employment opportunities for those who have recently come out of work and who are new on benefit claims, they can maybe be supported through the WorkWell coach to look at some different employment opportunities. So I think it's just building up that collaborative approach and seeing who is best to support in that local area and that for those local people. I don't know if anybody else has, any of my other colleagues have got any thoughts on that. Craig, you've been waiting patiently anyways, and we've mentioned MEC a few times.
Yeah, so I don't really have to say too much else now on that one, but I'm at Crompton Hospital, so if my sound goes okay, that'll be the reason why. But I guess it's firstly, Martin, it's great to hear using the website, and I'm sure other people are as well. Over the next 6 months, we hope to make some enhancements to that website to try and improve it even further. So that might be something to look forward to. I'll not put a timeline on that because it's the technical side of it, which is beyond what I do. But obviously, we're always open to feedback. But I guess part of my question is, and this might be to you, Kay, and this or to some of the advisors, is obviously through the website, a few months ago, we'd sent that message, or the DWP sent a message to people on universal credit. Now, some people would have been in work, so I actually got like a bit of insight into sort of the situations that people are facing in it. From what Martin said there, it moved away from lifestyle into more of those social determinants of health. So my question is, obviously we would send them, they're directed back to a job centre, but if they're not if they're not via a GP practice, which potentially these people are not accessing, is that a missed opportunity? Because ultimately, I mean, one of the examples that I saw last week was related to somebody's housing situation. So they're in work, they had 2 children, they'd been provided the MEC gateway, they'd struggled to search themselves for what was available because they just didn't understand, but ultimately that's probably the pressure on that person, which they indicated was leading to poorer mental health. And so I guess my question is around, is there potentially a missed opportunity here? I'm also hearing that potentially in some places they're at capacity, or there's maybe more of a waiting list. So are we just moving things from one place to the other? What's the best route to maybe direct some of those people to? Because obviously I could say go to your GP practice, but then I'm relying on that GP practice being part of a PAS scheme potentially, or having access to somebody like Martin or Jason. So I guess what's the route? Is it just go back to the job centre, and the job centre can then send somebody into Martin or the Jason, or is that not possible?
They could do, but when we think about this, the whole idea of the WorkWell is we'll have PAS and then we'll have WorkWell coaches. So there should be this support pretty much across the whole area, Craig. So it shouldn't be coming a postcode lottery on where have we got PAS advisors and where we haven't. So once this gets rolled out, and all the colleagues on the call today who's part of WorkWell, we should be able, we should have a list ideally of colleagues. So if you're aware of Craig as an ICB, if you're aware of somebody who's contacted through MEC who are struggling, it's maybe a case of, if you know where they are, we can maybe connect them to either the WorkWell coach or the PAS coach, or refer them back to the GP and they can be referred to the service. So we should have the service across the patch with a bit of luck. That's the aim. That's the aim, is to have this across the patch. So we should be in a comfortable position to refer people back to their GP practice to get referred in either WorkWell or PAS service to get the support they need.
I think that'll be good, because I guess obviously seeing, not always being frontline, but seeing bits of it, and obviously spend some time at the North Shields job centre and seeing people interact in that way. I guess it is, we can talk about prevention, but it's really coming in a lot earlier, because I guess some of the situations people are facing, it's no wonder that they are struggling, and because it's as I think Martin highlighted, it's not just one thing. It's also not really the health reason either. It's the things around that which then compound that health. So whether it's stress and worry and things like that. So yeah, no, that would be great if if we even know where people could go, because I guess we could filter through. And it's not thousands of people that have come through either. It's really people who've reached out because they're desperate ultimately, which I guess we can try and look to help and improve.
Yeah. Hannah's just put a note in the chat, Craig, to say, because obviously we've got local delivery leads. So the way it's done is Workwell is by the ICB geography, but then you've got seven local delivery leads. So there's going to be some slight variations depending on the locality. Hannah's just said, and I was just speaking to Hannah just before there, for Sunderland and South Tyneside, that they're going to have self-referral processes built in as well, which is really good. So again, once we know of the referral processes for each of the locales, we can let you know, Craig, and my colleagues know, so that we can make sure we're signposting people correctly to the support they need.
Yeah, no, that'd be great. Like I say, if we can filter that, because then I guess it just gives somebody something that maybe prevents them eventually coming in at a later stage where it's beyond the crisis point. So no, that'd be great.
Brilliant, thank you. Tracy?
Craig, can I just come in there? Okay,
Oh,
just with that one.
yeah.
In the situation you described there, Craig, they could access CAB and welfare rights as well and self-refer into that one for that sort of advice that they were looking for, particularly on the benefits side of it and the money side of it as well.
Yeah, Martin, thank you. So there's a couple where, so one of the enhancements is going to be, I think it's artificial intelligence, but it's going to be like automated trawling of services. So for example, there's a couple, the reason that it came about is that I thought the Met Gateway just got really, really popular all of a sudden until I'd spoke to Kay and realized like why people were asking. So sometimes I would just get an email saying like cost of living and finances, of which I thought they were suggesting a theme on the page about that. It obviously then turned out that I went into a full story with somebody about the issues that they were facing. But yeah, where we can, we will try and have as much information as we can up to date. But obviously in return, that should help you and other people doing this role, because I guess it should self-populate. But yeah, no, thank you.
Thank you. Tracy, sorry, we've hogged the meeting for the last.
No, that's fine. Thank you. And thanks everybody for today. I think it has been really helpful. I think from a practical kind of point of view, listening to some of the information, I think understanding what training we can when we talk about some of the softer skills, I think we need to look at the expertise. So really, I think the question is, it needs to be out there to the Workwell coaches or those people who are new coming into post. Now we know there are still some Workwell coaches or people who are going to be employed in these sorts of roles and not in post yet, hence the reason why we've got another one in October, which will be great. But I think we need to really try and capture what are the soft skills that people perhaps need that they haven't got already. I mean, earlier on, Martin was talking about System 1 training, for example, consent, taking consent to people, are people comfortable taking consent and things like that, interview skills, listening skills, all the bits and pieces. Now, I know we've got all of these little bits and pieces across, whether it's the Met Gateway, whether it's the stuff that the PAS service can bring. But I think it's pulling all of that together for those people who haven't got those skills, and how do we upskill them? So I think I did drop in a link to the survey earlier on in this session, and I think it would be really helpful for the Patient Advisory Service advisors if they could fill that in, just to give us an insight into their skills, because some of the questions in that survey is just about what have you got, but also understand where the gaps are. And I think this is perhaps for the likes of the LDT leads who are going to be sort of looking after some of those Workwell coaches that are coming into post, either new or have already got, like I say, lots of skills already, but we just need to understand what else they need. In terms of, so going back to, sorry, I'm a bit all over the place here, Craig's sort of comments, we are working with our comms colleagues as well, because we appreciate there's going to be lots of different ways you can refer in, or you can get somebody, help somebody and support somebody depending on whereabouts they are in their journey. They're not all going to be in primary care and going through the GP practice. We're going to have workforce. We're going to, be able to kind of look after our own colleagues and things like that. So I think there's lots of sort of, I've mentioned it to Karen earlier, I think of it as a bit of a circle, and depending on where you are in that circle, you might be referred in from different points within that circle, whether you're a patient, member of the workforce, etc. So, or somebody just looking for a bit of advice to because they need some reasonable adjustment at work. So I think really for me, this is about those work well coaches, those people who are perhaps, if there is anybody on this call, what else do you need to help you? So we've got a kind of a minimum or a standard offer that everybody can meet the requirements, but pick up the learning from our expertise around this virtual table kind of thing. So yeah, I just wanted to sort of put it out there. You know, this is going to be a lot of practical elements we need to pick up to support those new people coming in. Karen, I'm going to put this kind of back in your court because you have been having that expertise. Have you got any other suggestions how we can sort of manage this? I think the community practice is brilliant, but sometimes people need that tangible support to be able to deliver their role, and it's that's what we need to understand.
I mean, I think, you know, just getting my head around it, I think there's a community of practice, and the community of practice is about coming together to learn, and then there's probably something separate around discussing cases and casework and troubleshooting and that, which I don't think is this, because what we're about is the learning and improvement community and how you learn in your role. So from my point of view, how we can support, absolutely hosting the community's practice. This is just all so highly relational, isn't it? Everything is about the relationship, and so I can't help thinking that our, you know, if the support that we can or may be able to give is around those relational skills. Now, that's not to say we're expert in CBT approaches and those types of things, although having said that, you know, yours is a holistic approach anyway, by the sounds of it, in terms of that work well coach. So it's about having those really strong relational skills, and like you say, that coaching mindset and that coaching foundation and everything that goes with that. So I would, and really everything out. Forgive me if you think I'm oversimplifying this, so jump in, Martin and Jason and co. But it's almost like that, going back and going, what do I wish I knew at the start that I know now? And I'm sure a lot of that is just that knowledge piece. You know, who's out there, who you go to, who you can refer people to, and you can't, you know, that's knowledge, isn't it? But then there's the relational piece, is the bit that I think that we could support with potentially. I'm rambling, sorry.
Yeah, one thing I will mention there, I know Jason will pop in here and probably say this. So we had colleagues that were coming on board as patient advisors, while they were waiting for DBS checks done and all the rest of it. They spent some time on exactly what you've just said, Karen, getting to know your area, getting to know who your key partners are, getting to know what's available in that community for those local people, really getting to know that. MEC's going to help to do that. And like I say, if we can get more provision added on, that's not already on there. But spending some time getting to know that, because there's nothing worse if you've got a person sitting in front of you and you can't offer them any advice, so you really need to learn some of it beforehand. So if you can, if you've got some time, spend some time just really doing that investigative work, looking at what's available.
I would absolutely encourage that. That's exactly what we've done. You've got to get out and about and try and learn, and I guess upskill yourself, educate yourself, whichever way you want to call it. But, we tend to use a lot, and I think Martin would probably say the same. We tend to use a lot of community-based providers, basically. And yes, we've got a core, an amount of stuff that we've got available via DWP, but actually we use a lot of the community-based stuff. It's amazing how many people come in and I guess one of the first things they might say to you, well, I haven't done anything because there's nothing out there for me to do, which is, it's a bit like a red rag to a bull as far as I'm concerned, because it's like, yes, there is. And actually, if you don't know where to go, you're never going to access it. So I guess in that sense, we act as a bit like a mediator, a bit of a middleman, and we try and signpost those people into those organizations. And we don't just sort of signpost them once and leave them to it. We sort of signpost them into those organizations. We ask them then to come back to see us. So we're trying to manage that. Next time they're coming to see us, did you go along? How was it? How were things? So absolutely get out there and find out what's in the area. No question.
Yeah. Martin?
Yeah, I was just going to say exactly what Jason's just said there. And I think the way to, I think I can best summarise the PAS support is it's almost leading people up a staircase. It's one step at a time, but it's allowing them consolidation as well. It's not just rushing them up the staircase to get them to the end because they'll fall back down. It's finding the right support. It's hand-holding them through that bit of support and then always looking at what the next step is. I think we learned this quite early when we had people that were going into counselling. They were coming back out of counselling feeling great. But there was actually nothing at the end of counselling for them to pick up on the skills that they learned during counselling. So we would work with them during that counselling period, but also to make sure that once that finished, we had the next step in place. So whether that was transitioning into an adult education course or whether that was going in to do some voluntary work, it was always having that next step so the patient can see a clear, concise path forward and knowing exactly what step it is. Now, I use a staircase with people. It's almost like an action plan, but it's a staircase, particularly around people with mental health, because it always shows them they have progressed. Because a lot of the things that it says we haven't moved forward, when you can go back and say, well, you've done this, 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 and this, look at where you started. Visually, it's quite powerful for them. And it lifts the confidence. Because regardless of the health condition, 90% of the issues that we're having, it's confidence, it's lack of self-esteem, and it's just no idea where to turn. But absolutely 100%, you need to know what's available in the community, and that changes massively from surgery to surgery. Even if the surgeries are within 5 minutes walk of each other, the support that people access is very, very different.
Yeah, thank you.
I'm just conscious of time now. So can I just say thank you very much. I hope people have found this useful. Obviously, we'll wrap it up with some notes from the recording and just try and glean of, perhaps some actions that we can take. I did just pop a question in the chat there, Kay. If we have got new work-well coaches out there that are needing that extra support, could they potentially shadow some of the PAS advisors who are in GP practices at the moment? We
might need to think on that because it might be too many. We're very limited. We don't have a lot of PAS advisors. It sounds like we do, but they're very limited. So I'm conscious there's going to be a lot more work-well coaches. It might not be practical. That's why we're thinking of alternative ways we can still coach them.
Yeah. Okay. No, that's fine. But I think that, I found it really insightful, and thank you to Martin and other colleagues on the call. I think if anybody has got any other questions, can we or comments, by all means, you can use this chat and send them in. You can email myself, obviously. Kay, I'm sure you can take any questions or comments from your DWP staff. And I don't know if anybody's got any final comment.
Just to let you know, once we leave this call, because it's not our call, we will lose the chat in DWP. Sorry. So if anybody does have any questions that they want to put forward for DWP colleagues, feel free to put it on and Tracy might be able to gather those. And we can certainly look to answer any questions that anybody may have. But we'll lose the chat in case you think, oh, they're not answering, because as soon as the meeting ends, we'll lose the chat.
Okay. But that's great. That's been really helpful. We will push out some notes to everybody that's been on this call, just as a summary. And like you say, we'll set up another session for October once we've got some dates sorted. But thanks very much to everybody. And long may this continue. We will push forward and try and get this sort of little toolkit sort of package available for everybody. Okay.
Brilliant. Lovely. Thank you, everybody.